Welcome viewers, welcome friends, welcome colleagues, students, fellows, and my dear residents. This is Dr. Jaitly, your cardiologist on your favorite source of learning, MuniMeterHealth. Yes, welcome on MuniMeterHealth, your source of learning about cardiology and human illnesses and human heart awareness. So today, just like as I always do, my first things first, this is purely an educational channel. Just remember that. There is no medical advice. It's purely educational for our students, residents, and our colleagues. If you were to have an emergency or were having one, please consult your doctor right away. Get to the nearest hospital or dial 911. Now, having pushed aside those housekeeping rules, let's get to the crux of the matter today in this very short video. What is the pathophysiology of heart failure preserved ejection fraction? Now remember, heart failure, I think we have done quite a few videos on heart failure, so I do recommend that you please follow the playlist. So this way you keep the chronotropy and of course the chronology of the heart failure video sections on my site. So one of the things that's understood here is that when the heart failure has a preserved ejection fraction, remember the EF normally should be over 50%, either by an echo or by a nuclear scan, which is called if you will, nuclear scan is also called the MUGA scan, if you will. Okay, so one way or the other, the ejection fraction is calculated, it's more than 50. So normally 50-55% is a normal ejection fraction of a person. So anything that's in this range will result into a heart failure of a preserved ejection fraction, obviously. So here, and what is the definition of heart failure? Failure to meet the necessary oxygen demands of the body. Okay, by the heart. If the heart is not able to meet the oxygen demands to every tissue of the body, that is considered as impairment of heart function or heart failure. But here the irony is the ejection fraction is normal. It's maybe supernormal sometimes because of the compliance and the stiffness, as we may just call it. So essentially these patients have LV diastolic dysfunction. So they have a problem relaxing. Now we'll do our magic sketch here if you like. So we'll only draw the left ventricle. We have done the 4-chamber, but let's do one chamber here only because that's the one we are concentrating on. If this is your left ventricle, I'm not a good sketcher, but as you see, I'm trying to make left ventricle look like it's more half bullet shaped or more elliptical, if you will, but spherical and elliptical, if you will. And of course, here, if you were to look at the cross section, it'll look like this. So the LA is on the top, and blood is going in this direction, then out into the aorta from here. So what's happening is the concentric hypertrophy that occurs, in a setting of hypertension, will lead to LV stiffness. So this is what we are talking about on this upper panel, LV diastolic function related to stiffness of the left ventricle. So the stress, or we call it the wall stress, increases. As the wall stress increases, the left ventricular diastolic dysfunction decreases. Similarly, the compliance, we're talking about the compliance, the LV stiffness is inversely proportional to the compliance. So the left ventricle will not be compliant. It won't relax too well. Why? Because it is stiff. As simple as that. So the increasing stiffness of the muscle will make the ventricle less compliant. And therefore, because it is less compliant, there will be delayed filling. Filling will be more towards later part of this diastole than in mid-diastole. Remember, the left ventricle fills mostly in mid-diastole until the left atrium contracts on the top, and that contributes in a delayed fashion within the diastole as a left atrial kick, we call it, and that is roughly about 20 to 25% of the cardiac output. The cardiac output, as you know, folks, is anywhere between 5 to 5.5 liters per minute. Okay, so that's your normal cardiac output. Now, the other equation you should also remember while we're doing the cardiac output is stroke volume times heart rate gives you the cardiac output. Now, let's shift here to the left side of the panel. Here we're talking about the chronotropic incompetence. What do we understand from that? When the patient begins to exercise, the heart rate fails to rise proportionately to meet the cardiac output in that setting. We know the stroke volume are already less. Why? Because the ventricle is already hypertrophied in a setting of hypertension, for instance. It's not compliant and it is stiff. So we know the stroke volume, which normally should be about like 75 cc's, in these settings where you have LV diastolic function, the stroke volume is less. Okay, so stroke volume is already less. Now you do not have the heart rate response going up. So in other words, that is also relatively less. So what happens to the cardiac output? It also goes down as based on this. So that's one of the things that we also have to worry about, the chronotropic incompetence. Next, shift to the bottom of the slide here. LV impaired systolic function. Now, normally, ejection fraction is a good parameter. I wouldn't say it's a poor parameter on an echo. Time and again for decades, I think we have used ejection fraction as a criteria to ascertain whether these patients have systolic dysfunction or normal systolic function. So the fact is that the ejection fraction is say 50-55%, but we need to get into the tissue and the strain imaging. Now, Dopplers are more advanced, so the tissue and strain imaging will define whether the mitral annulus is moving vertically downwards or not, and based on which, there are parameters that you can look up in the echo text, if you will. Go to the bottom of the slide here. Skeletal and peripheral vasculature, especially the arterial and the compliance and the elasticity, that is also impaired in many LV diastolic dysfunction patients, partly because of the endothelial dysfunction moving to the right side of the panel here, or partly because of the hypertensive individuals, because that's one of the things that happens that leads to LV diastolic dysfunction. Now, coming to the right side of the panel, the endothelial dysfunction, which is prevalent in patients who are obese, patients who have insulin resistant, like the diabetes patients, or patients who are aging, past the age of 65. We're all aging. So endothelial dysfunction is starting to set in. By the way, aging also contributes to LV compliance and the diastolic dysfunction. Remember, hypertension is another indication for endothelial dysfunction. So many of these hypertensive individuals have endothelial dysfunction as well. Now, and that leads also to microvascular coronary dysfunction. Remember that. So that is another issue. MVCD is commonly present. Even in the presence of coronary artery disease, you can still have microvascular, or even in the absence of coronary artery disease, one may have microvascular coronary dysfunction. So that's a whole different subject. We'll talk about that at a later time. LA, remember the atrial fibrillation. The LA and the atrial fibrillation, the onset occurs because of the LA dilatation. So the LA size increases and therefore the LA pressures increase. And one may see that the atrial fibrillation could be an issue. And remember, atrial kick is about 20 to 25%, like I said, responsible for the cardiac output. And almost 60% of the patients will have, have atrial fibrillation in the setting of LV diastolic dysfunction. So it's a common finding and common association, unfortunately potentiating the action of LV diastolic dysfunction in the setting of heart failure preserved HFpEF, we call it, heart failure preserved EF. And last but not the least, what are the triggers? These are the various triggers. Remember, I call them triggers. Why? Because anything that worsens the HFpEF will be a trigger. So like an uncontrolled hypertension. So make sure that leads you a therapeutic goal and target. That control of hypertension is essential. Again, these patients should never be anemic, because that will lead to heart rate increase, and that can cause problems. Infection will again lead to demands high and heart rate being increased. Hypoxia will lead to a heart rate increase. So these patients cannot tolerate too well a tachycardia. That's the signal I'm wanting to give you. Pulmonary disease, especially because they have mitral, multifocal atrial tachycardias. They may have tachyarrhythmias or atrial fibrillation or SVTs. So all these things are not tolerable by the LV diastolic dysfunctions. Remember, especially with the HFpEF type of heart failures. Chronic renal failure leads to sodium and water retention. These two are linked here, and that's why I've shown them here. Sodium and water retention, or sodium and water intake. If an increased intake, also these patients cannot tolerate that too well. Chronic renal failure, or even acute renal failure, just a worsening of, say, creatinine going from 1 to 2, that itself is enough in an acute setting where LV diastolic dysfunction can actually worsen. Okay, so I think in a short video, I've tried to give you a lot of information here, just explaining the pathophysiology of what HFpEF is, and so this way one understands. And of course, remember this magic equation, that's mainly for medical students. Cardiac output is stroke volume times heart rate. Stroke volume is already decreasing these HFpEF patients, and as a result, if the heart rate does not rise proportionately, that's called chronotropic incompetence. Pulmonary hypertension, RV dysfunction is very, very prevalent in these patients. Also, almost like 70% of these patients will have pulmonary hypertension. So, and that is leading to pulmonary vascular resistance and a pulmonary arterial pressure increase as well. So, in a nutshell, you've learned the pathophysiology. In other words, it's not just LV diastolic dysfunction per se, it's also so many other things like the chronotropic incompetence we just talked about. It could be the pulmonary hypertension, which is adding to it, LV systolic dysfunction. Then we have skeletal abnormalities, endothelial dysfunction here, and then of course the LA dilatation or atrial fibrillation, new onset atrial fibrillation specifically, can also contribute to HFpEF worsening. Okay. All right, so looking forward to meeting you again on another video, another subject, another topic we'll discuss shortly, just like this. And stay tuned for more and more coming, more interesting stuff coming on MuniMeterHealth. Okay, looking forward to seeing you again. And of course, if you like this video, don't forget to press the like button. And of course, I hope you're subscribing to my channel, so this way we are all together. And do not forget to ask any questions, comments, or suggestions. So this way, we'll make it a point to answer your comments within a reasonable period of time, within 24 to 48 hours. Okay. Thanks again for watching MuniMeter.